Well, thanks everybody for coming. I gave a similar talk last year. If you were here last year, thanks for coming back. There is some overlap with what we did last year. Hopefully it flows a little better. And then we'll talk about some new things we're able to do in the department at Grand Itasca. So we're going to talk about common causes of neck and back pain and what we can do about it, as well as those department updates. And I jokingly tell people all the time that I don't have any back transplants in my cabinet in my procedure room. And pain is complicated. The diagnosis of pain is complicated, and what we can do to try and treat that pain often has multiple sort of elements. And we are able to do a great job, I think, of helping people treat their pain in the department, in our partnership with CDI at Grand Itasca. I am a neuroradiologist. I train at the University of Chicago in Northwestern, and I live not too far from here. My 3-year-old's often in the little daycare in the morning, and I do, personally, about 1,500 injections a year at Grand Itasca. And most of them have to do with pain. Now, a fair percentage of them are pre-MRI, like arthrograms, but at least as many, probably more, are direct treatment of people's pain. There's the crew. I've updated photos this year for anyone who was here last year. That'll be the highlight. Yeah, so that's Griff. Griff is 1 as of this year, and then it's Tess is the oldest, Claire, Declan, and Liam. Yeah. So why is it so hard to figure out what hurts in your back? Well, for better or worse, your back has lots of parts. And we can see certain parts better than others with different tests. And we can figure out where the pain is coming from, sometimes based on the description of a patient's pain, sometimes on the exam that your doctor does, or I might do in my room. And sometimes I get to be a bit of a tiebreaker and actually put a needle where I think the pain is coming from and numb it up. And people tell me afterwards, yeah, you got the spot or you didn't. Unfortunately, almost everybody gets back pain. 85% of people will have significant back pain that they go and get treatment for. As a radiologist, I start my approach to back pain from pictures, from diagnosing where the pain comes from. And a lot of times we start with an X-ray, which can show us fractures, it can show us how high the discs are, it can show us joint hypertrophy, so arthritis is sort of, X-ray is obviously the tool to start with in joints, but we can see the little joints in the back to some degree on X-ray as well. MR shows me, is there a nerve pinched and which one? Why is it pinched? Does a facet have edema? Is it swollen? Is there not enough room for the cord and nerves in spinal stenosis, or does the cord itself have an abnormality because of multiple sclerosis or because of prior trauma? And so I really believe my most important job is just figuring out what hurts. Sometimes just knowing is a great help for us to kind of deal with what we're going through, and then it sets us up for the right treatment for our pain. The hardest thing to get over, whether you're a patient reading your report or you're me trying to look at an image, then go and meet a patient and figure out what we ought to do next, is that things that look bad don't always hurt. If you take a classroom of college kids who all swear they don't have back pain, haven't had bad back pain, and you do an MRI of their backs, 30% of them have an abnormal level. They have one bad disc, they'll have transitional anatomy, and they don't have back pain. So you get this report, and we give you this beautiful description of every disc in your back, and it sounds horrible. Oh my gosh, all of them have all these problems. That's not necessarily where the pain comes from. What I mainly do from a procedure standpoint is this interventional pain therapy, where we use image guidance. Oftentimes it's that live x-ray in the room, the fluoroscopy machine. Sometimes it's ultrasound to get a needle where we think the pain's coming from and treat it. And one of the main goals is to get people back to the things they want to do. It's interesting, I find sometimes when couples come in to me that one of the couple asks me to tell the spouse, don't let him do this anymore, it's killing him. And I always kind of smile at that, and I think that makes some people mad, but I really try not to tell anyone what they can or cannot do, because my goal is not to minimize your pain to the lowest possible level. It's to get you to do the things you want to do in a way that you're not thinking about the pain while you're doing it the whole time. The advantage of what I do versus, say, a drug you might take is that I'm putting what therapy, what medications I have right at what we believe is the source of the pain. And sometimes it's a bit of a course of discovery, but sometimes we know where the pain's coming from and we can very definitively fix it. I'll talk in some detail about kyphoplasty, where we can actually fix a fracture of the spine from the inside. We can put a cast on the inside. It's like my favorite thing to do. I can block any nerve in your body. I can put numbing medicine, I can turn it off, and we can figure out, is that nerve carrying the pain, and then maybe figure out why. And then with the steroid therapies that we do very commonly, we can reduce inflammation without as many of the side effects that come from having like oral steroids, particularly oral steroids over a long period of time where it's absorbed into your bloodstream. I don't cut out discs, I don't replace joints, I don't fuse spines. I have friends who do. And we try and avoid that in my room when we can. One of the ways that I conceptualize pain, particularly in the back and neck, is arthritis. Arthritis is sort of the common pathway by which all our joints end up getting used up to some degree. And it can happen when you're young because you had a severe trauma. It happens when we're older because we've been doing stuff with them for so long. And a painful facet joint, these little joints in our back that are so essential to our bending and twisting here, they swell. They get arthritis, they get hypertrophied, and the joint is made of two pieces of bone with synovium, so slippery bone, with a capsule around it. And there's a little bit of fluid, a tiny, tiny bit of fluid in it, and when they get abnormal, they can get a lot more fluid. And that's the analogy to like the bum knee. When someone has a very arthritic knee, it often, you can physically look at it, it's a big knee, and when it's acting up, it swells up, and you can see that. I mean, you can't see it in your back, but I see it when you come in and have an MRI. And why do our joints get big when we get arthritis? Well, it's a natural response of our body to try and reduce the motion of those joints. It's trying to get your body to use a different joint, and that joint kind of gets bigger, the edges start running into each other so that joint can't move as freely, and that's sort of a physiologic response, but it also ends up causing pain when those edges bang into each other. When the joints get big, when they hypertrophy, instead of being tightly opposed, they start swelling, and they actually slide back and forth just a little bit as the bone grows. And what that does is it actually puts shear stress on the discs. So your discs are unbelievably well designed to bounce along all day. But as soon as you start shearing across the disc, there's only some thin fibrotic pieces that are called the annulus of the disc that tear. And that's when pieces of disc fall out. And if you're lucky, that piece of disc falls somewhere where you have some fat and it doesn't do much. But if you're unlucky, it falls in between a piece of bone, a nerve, and where the disc is coming out of, and now that nerve is being compressed, it's being distorted, it's being smashed by the disc fragment, and it doesn't work normally, or it's painful. So what distinguishes, what's that story of facet disease? So I started talking a little bit about it. It's really hurts in the morning, and then I get going, and as long as I'm doing something during the day, I feel pretty good. But by the end of a long day, particularly a strenuous day, it's just killing me. And I might not be able to do anything the whole next day because I overdid it yesterday. That's kind of an arthritis story, and I hear that in people's backs, and I see it with this facet disease. the pattern, where the pain goes, is really important to me. My rock star techs who are in the room, they come into the room, they pull up your MRI, and they say, Chris, this person has pain going from here to here. So it's going from their mid-back into their thigh. Oh, that sounds like facet disease. It's going from their back all the way to their foot. Oh, that sounds like radiculopathy. That sounds like a nerve that's being pinched. So that's a big distinction for me, and it really guides what I can do to help that pain. I see, not infrequently, people come in, they complain to their doctor about back pain, and they might get an x-ray of their chest or their thoracic spine, their back. But our thoracic spines are held together by our ribs. So they have this whole extra set of like bony stabilization. So it's actually really uncommon to have bad thoracic disease. Now, if you have really scoliotic spine, it's very possible. If the rest of your spine is in bad shape and you've been kind of overusing the thoracic spine for bending and twisting, yeah, it can happen there. But most of the time people come in and they have pain in their, inside the edge of their shoulder blades, or scapula. And it's those knots, you know, people get on the inside of the shoulder blades, why it's so nice to get a massage once in a while. That oftentimes is actually from the lower neck. So the most mobile facets in our whole body are these lower neck ones. They do the most work. Now, they don't carry as much weight, obviously, as the ones in your low back, but they move the most. And so people commonly irritate them, and they'll get this neck pain that's sort of, a lot of times it's one side more than the other, and it goes into that sort of inner shoulder, goes down the angle of the neck, but then it also goes down the shoulder blade, on the inside of the shoulder blade. And you know, people show me their thoracic spine MR and go, why does it hurt there? And I go, oh, actually, it's your neck. I go, what? That's what it is. There's these patterns I'm talking about. So 5, 6, and 6, 7 are the most mobile joints in your body. And in here is just such a common place for pain. And it doesn't have to come from your neck. It might come because your purse is too heavy. Sorry, ladies. It's like, it's a thing. But if it comes from your neck, you know, it's going to go there. So when I think it's a facet joint, we will sometimes go direct to the facet. Sometimes we'll do an epidural injection because the epidural space touches the facets. But if we're going to do a direct facet injection, this is what it looks like. So we've turned the camera so that it's looking at an edge down the spine. So it's opened up these facets. So when you look from the front, the facet joints actually, they're kind of big on this guy, but they look bigger when I twist just a little bit. So I twist so I can go put the needle right into that joint. So I've twisted, I've put the needle right into the joint, and we put numbing medicine and steroid in. And these work really well if that's what it's coming from. Sometimes I have really dramatic examples. I've had a series of guys my age who were excellent hockey players, and they have one really terrible facet. And they have been to everybody, and they've done all these things, and they can't figure out why they hurt. And I do their one facet, and it's sort of a magical thing because they didn't know where it was coming from, and I can improve it. But you know, the initial approach might be steroids. Most of the time, the steroids that we put in last, you know, have a measurable effect for 2 to 3 months. And people often feel better longer than that because back pain has this, there's the spine component, but there's also like the muscle spasm and the fact that you're walking funny to kind of guard the thing that hurts. And so if I've made you better for 2 months so that you're walking better, well, that part of your back may not inflame up quite as fast. And that ends up being a big thing for a lot of patients. But the nice thing about facet disease, it's one of the few diseases where I have a really good treatment that lasts longer than a few months, and that's a rhizotomy. So these we do maybe once a week in the department, and we bring a needle down instead of into the joint, on the edge of the joint where there's these little tiny sensory nerves that run to the joint capsule, and they bring pain from the joint to the spine. And you know, one of the benefits of a spine fusion is that a painful joint is no longer moving. And so I'm giving one of these benefits where you don't have pain coming from that joint, not because it isn't moving, but because, you know, that pain has been turned down. You know, it lasts, the published number is 8 months. I find most of my patients are good for 12 months, sometimes more. It certainly lasts longer than the steroid injections. It is repeatable, and maybe half of my patients will get a second one, only 5% get a third one, and the reason I explain to them is each time I've kind of turned the pain down, so you come in with an 8, we get rid of it. It's a 2, you know, and you can just, a lot of times we don't get rid of 100% of the pain, but it fades into the background. It's no longer much worse than your shoulder is, and you kind of go through your day and it goes okay. You know, when it comes back, it might come back as a 6. We do it again, it comes back as a 3, and at a 3, you kind of just ignore it, and that's okay. They are done in our little procedure room. Most patients will get moderate sedation just because it's a little bit longer of moving needles around in the back. It itself isn't necessarily more painful than the other things I do, because once I got these needles in position, and it's a very exacting spot, we do a block. And so people, when they leave the rhizotomy, typically feel really good for those few hours until the block wears off. I put a little steroid in that day to kind of cover, because oftentimes there's this unpredictable gap from the day I put the energy in until the day the rhizotomy works. And for some patients, it's 5 days. For some patients, it's 5 weeks. And instead of having you at home with this sort of irritating pain, we put a little steroid in that day, which we did not do on the block day. And that kind of bridges that period of time between the rhizotomy's completion and its effectiveness. The best analogy is it's an ice pack. I put an ice pack in that's cold for 2 months or 3 months. So it's reducing inflammation, and you know, it's not cutting out a disc, it's not fusing it, it's just you putting an ice pack right where the inflammation is. Sometimes, particularly in these joints, when you have inflammation and pain and you're guarding it, when your back is sort of twisted around it, it actually ends up putting more stress on these joints. So just by getting you back to a natural position and getting you to your natural activities, walking around, swimming. You know, we have a lot of patients that go over to you know, the heated pool and get wonderful relief from their back pain, as much as I can do sometimes with these injections. I tell all my patients, if there are things that you've been doing that really help your back, if I put this injection in 3 days from now, you have no back pain, don't stop doing the things that help, because it'll help the shot last longer. Conversely, if there is something, and I'll now tease the guys, if you go play 36 holes of golf 4 days after I do this, it's gonna work that, you know, the shot's gonna wear off sooner. The weakness is we do have to do a numbing injection to prove that a rhizotomy will work. So no one comes in and gets a rhizotomy the day they meet me. It's we think it's Facet disease. It's a really good pattern for it. Maybe you've had a steroid injection that didn't last long enough, and we're gonna numb that nerve, and you're gonna tell us in an hour if that numbing did the trick. You know, did that get 80% or more of the pain that we're trying to treat? They don't work for pain that goes all the way into your hand or your foot. That's a different thing we're going to talk about in a minute. Oh, interlude. There's our beautiful lake. Okay, go on. An overlapping thing that's hard to sometimes diagnose, and it can come up after a rhizotomy, it can come up after someone's had a hip replacement or a knee replacement, are these sacroiliac joints. And they're big joints that essentially hang our pelvis off of our lower lumbar spine. So this is the sacrum, this bony body that's fused together that has multiple nerves going through it. And this joint here is the sacroiliac joint. Patients with sacroiliac joint pain often come in and they don't really have mid-back pain. They have this pain that's out here. It's not focal pain over the hip, which is often this sort of bursitis, this friction issue that's pretty common. It's not groin pain from the hip joint itself, and it's not that midline back pain that's often the facets. It's this outside pain, and it's hard sometimes in the office for your doctor to know where your SI joint is, because this big sort of lobule of the iliac bone guards it. When I get you under the fluoro machine, I sometimes, and I get some dirty looks for doing it, but I'll push right on the joint and people jump, and it's pretty obvious that that's where a significant portion of someone's pain is coming. Women who had, multiple vaginal childbirths have a higher incidence of it. As I said, people who've had joint replacements I see a lot of. And unfortunately, this is one of those diseases for which physical therapy and occasional steroid injections is probably the best treatment anybody has. There is a SI joint fusion, this tri-pointed, like 3-pointed device where they try and fuse across the joint that got approved by the FDA last year, and my friends who are pretty famous PM&R docs in Chicago, they don't like it. They don't think their patients are getting a lot better from it. I have some patients who have chronic SI joint pain who are technically fused, but they were in a big car accident or a horseback accident, and they had to fuse the pelvis, and just pain persists there. So surgery doesn't work well. And then rhizotomy, because the nerves are kind of all over the place, the initial research on rhizotomies didn't have great outcomes, and so it's still sort of an investigational thing. It's not something that insurances will let me do. So I have some people that come in a couple times a year for an SI joint injection, or both SI joints, and that's part of their treatment. It's not the only treatment for their pain, but it's, you know, kind of the best thing we have for them. So, separate pain. Pain that goes from your back or your neck all the way into your hand or your foot. And this is that pinched nerve. And pinched nerve, I think people just think of like an electric shock, and sometimes you get that feeling in the neck, but I'm actually talking about stuff that goes all the way to the hand or the foot, or rarely in the thoracic spine, sort of around a rib or like under the bra line. And this is disc disease that matters. So it's that piece of disc where a lot of times there is some pre-existing back pain. Maybe people have had back pain for a long time, but all of a sudden, now their leg's not working right. And it's because they had some arthritis in their back, which they were dealing with, you know, maybe without ever having to talk to their doctor about it. And then that shearing across the disc resulted in a tear, and then a piece of disc that fell out in the wrong place. And our bodies react to these discs in the wrong place. Interesting, just like a sliver, like a foreign body, something that is where it ought not to be. And so we get macrophages, cells that actually try and clean up to eat some of that piece of disc. I divide these patients up into sort of 3 categories. So one is people with just pain, 2 are patients with pain and numbness, and then patients with weakness. So, you know, pain is something that we can almost always help. Steroids are really good at, this ice pack effect is really good at controlling pain. Numbness, in the sense of like sometimes it tingles a little bit, is also something we can help. Numbness, I can't feel it when I put my shoe on, is a problem. That's really severe compression of the nerve, and it's often related to weakness. When I walk, I actually drag my toe, or when I, you know, pick up a pen, I can't use it the way I used to. And for those patients, sometimes a sooner rather than later surgery is the right thing to do. You know, the weakness is sometimes hard, though. Is that true, like, you can't use the nerve weakness, or is it just your body's telling you, whoa, 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 that hurts, stop? I find a lot of patients can kind of force themselves to walk on their toes, and they don't really have a weak nerve, but it just hurts a lot, and they don't want to do it. And that's, you know, they tell me they're weak at first, but it's less so. We do these injections quite often, so we bring a needle down right next to where the nerve comes out of the spine. And so each of these nerves are coming out what's called the neural foramen. And typically what's happened, I kind of have a model of it here. You know, this piece of disc has fallen out. A lot of times it's not in the middle, it's off to the side where the nerves live, and it's pushing the nerve between the joint and the disc. And so we bring a needle down right next to the nerve, and we put in a drop of contrast to prove that we're in the right spot. And then we put in numbing medicine and steroid. And the numbing medicine is actually an important diagnostic step. So when you get off the table, did that pain you had coming in, did it go away? Did it get blocked? Because if it is blocked, then we're on the right nerve. And should, unfortunately, another piece of disc fall out and you get really profound weakness, the surgeon already knows exactly where to go. You know, that itself can be a very important piece of information. The good news is that for patients who've had, you know, a sudden painful leg or a sudden painful hand, that process I talked about, the macrophages trying to clean up the disc, it sometimes works. You know, not everybody needs to go to surgery, and I trained with a pediatric neuroradiologist, a friend of mine, and he was doing these procedures with lead on, and he popped a disc in his back, and he refused to get surgery. And 9 months later, his pain was gone. But it took 9 months. And what I offer to patients who, aren't interested in an urgent surgery or don't need it because they don't have weakness is the ability to put some steroids in there and make the pain less. And it sometimes takes a couple goes during that 9-month period and give the disc time to get retracted almost an unmeasurable amount, and give the nerve some time to kind of scar down a little bit around it. And people sometimes do well. Sometimes, unfortunately, patients will have a piece of disc on a nerve and it hurts, and they get surgery and they get a very nice cleanup of the nerve where the nerve is floating free, there's nothing pushing on anymore, and they still have pain. Because nerves are weird, and sometimes when they get used to having pain a lot, it's hard for them to unlearn that. Just one of the things that complicates, my attempts to treat this pain and the surgeon's attempts to treat this pain. The other thing I haven't talked about much, in part because the interventional therapies are limited, but I actually have a lot of patients with it, are spinal stenosis. So some people are just born with a thinner spinal canal. Some people just have really tremendous arthritis and things start shifting around and the facets get big and there just isn't room for the nerves to kind of transit through the central canal before they get to their level to come out. And the classic treatment for that is surgery, but we all get to the point in our lives where surgery is just a terrible option. And we can do occasional epidural injections. We can try and figure out if maybe the pain isn't all from the spinal stenosis. A lot of times it's from the facets that have contributed to the stenosis, and I can treat the facet part, and I might not be able to treat everything, but I can help that pain. Unstable conditions in the back, whether sort of subacute from pars fractures or from trauma with an actual tear through the ligaments and breakage of bone. One of the things that sometimes my surgical colleagues don't advertise very well, because people are naturally scared of surgery and they don't want to scare you anymore, is that any surgery, but particularly spine fusions, have sort of a natural history. So, a good surgery will have people feeling great in 6 weeks when their rehab is done. But if you fuse the spine, there's those levels don't move anymore. They don't contribute to when you bend over and tie your shoes. So the other levels have to do more work. They have to bend a little further, just an extra degree or two. And that extra degree or two makes their arthritis happen faster. And so even for young patients, sometimes the most common facet disease I see are people who had a fusion 8 or 10 years ago, and now the level right above it is just in bad shape because it's had to do so much extra work. And so why do they do fusions at all then? Why aren't they just snipping away these little pieces? Well, when you go into the spine to do surgery, in order to see anything, they cut this little piece of bone off. It's called the lamina for almost any back surgery. And so they've pulled this little piece of bone off. Well, on the front side of that bone, there's this thing called the ligamentum flavum. It's one of the things that can get thickened and cause spinal stenosis. So by taking it off, you've helped spinal stenosis. They've done something good. But they've done something bad, because the ligament flavum is this thick piece of the stabilizing structure in your back. And once it's gone, that level now can kind of flop around a little more. And it's hard, and it's one of these things that is constantly researched about, how do you balance those two things. One, you need to make space, but when you make space, you create instability. Do you stop the instability by, fusing it? That makes sense, but then you get this arthritis later. Do you leave it alone? Well, then you might get arthritis right at the level that you fixed, because it's now not as stable without all those ligaments it normally has. I hurt my neck by hitting that thing really fast on my snowmobile, and I sympathize with facet pain. I had it for a few months, but I was fine. I could have broken something, transition to compression fractures. So one of the things that I love doing, because unlike these other things we're talking about where, chronic injuries to nerve are difficult to treat, and facets we're not transplanting your back. We're just trying to treat it. In a fracture, I can fix it. I can put a cast on the inside of the bone. And it is a common event. It doesn't have to be from a major fall. You don't have to fall down the stairs if you have osteoporosis. This can be something that happens from normal activity, or it can be from a really minor trauma. Just slipping on the wet floor in the kitchen can cause people to have a broken back. One of the things that's kind of amazing about the way our spine is designed is that we break our back in this way from these compression fractures. And you don't typically get leg pain. You don't typically, it's not a paralyzing event because our back breaks in such a way to protect the spinal canal. The problem is you can't put a cast on the back from the outside. It just doesn't work. The pain is severe because every time a person takes a deep breath, every time a person goes from lying down to sitting up to standing, they're changing the angle of the force through their back, and so this little fracture moves. And fractured bone that moves is going to heal a lot slower than fractured bone that doesn't move. That's why we put a cast on people's hand fractures. It's because if you move the bone, then the new bone that's trying to grow across that space is going to get broken up, and it's not going to heal very quickly. And with 95% effectiveness, we can take away the pain from that fracture. And we will do it even within days of people having the fracture if their pain is severe and it's just not being controlled with other things. I tell everyone that comes in from one of these that we don't have to do it. There's, your body will heal this fracture eventually on its own. And so if there's something that makes taking you to the OR and putting you in moderate sedation to do this unsafe, then maybe we can't do it. But if someone can go to the OR and lie on their stomach with me for 45 minutes with the help of anesthesia, I can, through a needle, put some cement into the broken bone, and the fracture is still there, but the movement stops. And so just like a kid with a broken arm and a cast, the pain stops once it's in the cast, or most of it does, because it's not moving. The periosteum, this living edge of all of our bones, isn't being stretched every time they take a deep breath. Pretty pictures of what it looks like. So we get into the bone. We use, again, these sort of fun angles right down the edge of the bone. And I think this is my first case I did in Minnesota. And so this is a normal height bone, and this one's broken. The top edge of that bone has fallen down. And it was because there wasn't enough support in here, and something stressed that bone. A lot of times these happen right here where the thoracic spine and the lumbar spine come together, because your body kind of has a natural curve there, and sometimes when you fall you kind of crumple up, and that's where that pinch happens. And so this top of the bone pinched and fell down, and you can see this is where the cord and the nerves live, and this back edge of the bone is in really good shape. A lot of times a little fragment here will move back a millimeter or two, but there's this big thick ligament, posterior longitudinal ligament, that lives there, and it actually holds the piece of bone where it needs to be. It's one of the design features of your spine that's really great. But this fracture is going to move around for months and hurt for months. And we can stop that movement, stop the pain, and stop what sometimes happens, is really hard to predict when it's going to happen, of this bone continuing to fall down. So sometimes that bone continues to fall down, and you go from having a little tiny angle from your fracture to having quite an angle from your fracture, and then that stresses other things in your back, and having that big hump in your back is itself a risk factor for having back pain. And one of the things that in my mind justifies the procedure the most, this thing that heals on its own, I'm going to take you to the OR, I'm going to expose you to the risk of some anesthesia, is that not doing things is a terrible thing for anyone. Olympic athletes, they test this thing, it's called VO2 max. So guys that are swimmers, rowers, they have this unbelievable ability to put out, to convert energy into motion, and they lose 30% of it in a month of not training. When someone is in their 80s, they fall, they fracture their back, and the only thing that feels good is to stay in bed or stay on the couch all day. You're going to lose a significant 10–20% of your strength a week. And we can stop that process by stopping the pain and getting you back up. And if you get back up, you might be as excited as my daughter surfing without the rope for the first time. Quick interlude about opiates. So this is a big topic among pain physicians, among patients who have chronic pain. And why do I do these things? Why do I put steroids in when they wear off? And it's because we don't have any magical pill to take away pain that doesn't have complications. Opiates are by far the most effective pill to treat pain. It's just a general concept of pain. But 25% of people who are on it for more than 2 weeks will have some complication. And after months of chronic opiate use, a not small percentage of people will do things they wouldn't have done otherwise if they weren't on these opiates. But the positive, so you'll hear people all the time and they'll say, there's a 10% risk of that and 10% sounds really bad. Well, that's a 90% risk of everything being fine. So, 70% of people with severe chronic pain probably do benefit from opiates. The hard thing for doctors nowadays is figuring out who is going to benefit, who is not, what the right dose is. And the science of that is very hard to study because pain is so subjective. People say, yes, my pain is a 6 today, a 4 tomorrow. Did anything even change? It's really hard to know. What were those complications I was talking about? I mean, for many patients, it's just constipation. The one that I see that ends up being a major thing for people who have more than one thing that hurts is this thing called hyperalgesia. And that is, if you've blocked your pain receptors all day, every day, when something painful enough gets through that block, it's like a bright light in a dark room. Your body kind of has an exaggerated response to it. And sometimes I see it in patients who've been on pain medicine for a long time when I just go to numb their skin and they hit the ceiling from that numbing poke. And it's probably a side effect of the drugs are on. It's not anything wrong with the patient. It's just that their pain perception has been warped. We know this thing exists, hyperalgesia. We know it happens with larger doses of the drug, but we really don't know who's gonna get it. Okay, we can calm down. Don't talk about drugs. I'm really excited about summer. My friend just did this beautiful, I know, my friend just did this beautiful video of Pekegama Lake. He sells homes, and it's a beautiful marketing video, and all these guys are fat biking, and they're around the fire, and it's just like so well done. I'm like, man, that would have been really cool to see in December. Right now, I need some lake. We're going to talk about new things in the department. So one of the things that has really helped me do my job is a little over a year ago, some of you may have had to suffer through being out in the outside in the cold in a van getting your MRI done. That is no longer the case. That was when we had taken out the old MR and we're putting the new one in, which actually takes weeks and weeks to do. We have this new MR. It is world class. It is what the backbone scanner at Northwestern University, where I train, where they do $1 billion of medicine around imaging each year. That is their workhorse. We have one here, and the pictures are beautiful, and they really help us. I think our spine imaging was pretty good before. It's excellent now, and some of the things that we couldn't do before, we really can now. So, I'm able to do breast biopsies on our MRI. I'm able to do prostate MRIs, which are not a screening study, but a study for patients who have really high risks for prostate cancer, and they haven't been able to find it on the standard sort of random biopsy or ultrasound guided biopsy. And so we can actually pick out lesions, and we send them to a company, and they come in with their ultrasound machine, and Dr. Novak is looking at a live composite of the MR that we've done, and I've made little circles on, and the ultrasound that he's seeing real time, so he can put the needle in the things that look most worrisome to me at MRI. And MRI is actually a really good tool sometimes for liver, pancreas, and renal disease, and that is something that in the 10 years between the two scanners, the technology is completely different and is really fantastic. it's really good for younger patients to reduce their dose, but it's also good for older patients where we've been following, say, a mass in the kidney for a while, and we're trying to decide, are we going to do something about it or not? Sometimes the MR is the deciding factor. Yeah, you can leave that alone. That's benign. Don't worry about it anymore. Or, yeah, that's got to come out. And you don't have to wait for it to present itself as much as you might with CT. We also got all new ultrasound machines, and we're doing better cardiac, fetal, and vascular imaging in particular. We are getting the 3D tomographic mammography machine here in the next few months, and it's going to help us find screened breast cancer, so breast cancer you wouldn't know about for any reason earlier. We're going to be able to see these lesions when they're smaller and more treatable. Something I think may be relevant for this crowd, we, with the CT scanner, which is only a year and a half old, is able to do these low-dose lung screening CTs with extremely small radiation doses. And one of the people I trained under worked on this study that was, so good it basically flew through the U.S. Protective Task Force to say, yeah, we should start screening people for this. And so the idea is we're going to screen people for lung cancer, but we're not going to screen everybody for lung cancer. We're going to screen only the patients that are at really high risk. This may have happened to some of you. You get a CT, say, of your belly for belly pain, and we find one little nodule in your lung. Well, most of those are benign, particularly for the people who've never smoked. But for patients who have years and years of smoking history, the chances of that dot being cancer is pretty high. So we're going to put them through the scanner, and it's going to be really low dose, and we're going to find these cancers before people are coughing up blood, before people have chest pain. And this really large multi-center study showed that you save a life every not just find a cancer, you actually save someone from dying from lung cancer for every 320 people that you sign up for this program. And that may seem like a lot, but that's actually an unbelievably strong number for a modern screening program. So, for something this size, and there's a decision process. So is the person sick or not? Sometimes, a very subtle pneumonia can just look like one dot, and if it's someone who has a lot of smoking history, you might be worried, but you might want to treat them first and then check again and see if it went away. Well, then it wasn't cancer. Sometimes we'll use our PET machine that shows up every week on Thursdays here, and we'll put a person through a PET study. Some patients have lots of emphysema in the lungs, or maybe the nodule's in a place that's just a little riskier to get to, and we don't want to do a biopsy unless we are very concerned about it. But I probably do 3 or 4 lung biopsies a month now, and this screening program isn't even that well established. It is something that I would, if you fall into this category, if you're in this age and you've smoked quite a bit, it's worth talking to your doctor about whether it's something that would be appropriate for you. Real quick on the CT again, 9 times better than finding a small cancer than a chest X-ray. Chest X-ray really isn't the test if someone's worried about your risk for lung cancer. It's totally the test to start with if they're worried about pneumonia, or if you just it's often the first test for many complaints, but it's not the test to screen for lung cancer anymore. Okay. I primarily work with ordering physicians, chiropractors, nurse practitioners. I work with your primary care doctor or the people that are otherwise treating your pain. I don't run a formal clinic with office hours, but as part of every procedure, I give people my opinion on what I think we should do next, depending on if this works or if this doesn't. That's just kind of, I think you have to do that each time I see someone. And then, sometimes if it's more complicated than that, we'll set aside time just for a formal consult. But most people kind of want to get that first injection, because for me, that's also a test. It's figuring out, is that what's going to work or not? Numbers. Pain is very common. We can help. We are here to help your pain. Some things we help. We have the best possible tools for it. Sometimes it's just diagnosing your pain so that the right thing can happen afterwards. Thank you, everyone.